This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh. We have been coming to you since October of 2016, going through the content specifications for the American Board of Pediatrics for pediatric hospital medicine. We have over 50 episodes for you. This is going to be another very good episode. I'm very excited about this one. This is part 2 in our series of racism in medicine. I am very fortunate to have 2 expert guests with me to help kind of steer us through this conversation because, as I said at part 1, I do not feel comfortable being the one to steer us through this conversation. So, and just as a reminder, everyone listening, as always, there is free CME credit available courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Just click on the link at the bottom of the podcast. So without further ado, I'm going to introduce our guests and we're going to get started. So first, I'd like to introduce Professor Tomar Pierson Brown. Professor Pierson Brown received her JD from Case Western Reserve University School of Law and a Master's of Law, LLM in Clinical Legal Education and Systems Change from the University of the District of Columbia, David A. Clark School of Law. She's currently the Associate Dean for Equity and Inclusive Excellence at the University of Pittsburgh School of Law, where she also directs the Health Law Clinic, a medical legal partnership between Pitt Law and UPMC Children's Hospital of Pittsburgh. So, Professor Pierson Brown, thank you for joining us.
Thank you so much for having me. I'm excited to be here.
All right. And then our second guest, Dr. Sylvia Owusu-Onsah, is a board-certified pediatrics and pediatric emergency medicine and is currently an assistant professor of pediatrics here at UPMC Children's Hospital of Pittsburgh. She serves as the EMS medical director for UPMC Children's Hospital of Pittsburgh. She studied at prestigious institutions such as the University of Chicago, Pritzker School of Medicine for medical school, and Johns Hopkins School of Medicine for 2 medical fellowships, pediatric emergency and emergency medical services, and is triple board eligible. Dr. Owusu-Onsah also received a Master's of Public Health with a focus on health policy. She's one of the few in the field of medicine with this trifecta niche, as she takes care of children in the out-of-hospital and in-hospital setting. The children in her care range from mildly ill to critically ill. She also oversees emergency medical providers and educates them on how to take care of children in the out-of-hospital setting. She's passionate about children, has spent a third of her lifetime advocating for children's health through local, regional, and federal government legislation. She has numerous written works pertaining to children's health directly and issues related to children's health in the form of blogs, op-eds, articles, quotes, podcasts, and manuscripts, including The Hill, The Baltimore Sun, Parade Magazine, Romper.com, HealthyChildren.org, U.S. News and World Report, Huffington Post, and the New York Times. In the field of emergency medical services, she's an expert on pediatric care in the EMS environment and currently serves on national committees and has written national policy statements and a technical report on how to best take care of children in the EMS environment. She's lectured in numerous academic settings, institutions, and conferences on the importance of pediatric emergency health and emergency medical services. She holds a rare niche, and she's married to a paramedic and has 2 beautiful daughters of her own who have aided her immensely in becoming both a better pediatrician and mother. So, Dr. Owusu-Onsah, thank you for joining us.
Thank you for having me. Pleasure to be here.
So I think the first thing we should do is, as always, get our disclosure statements out of the way. I will go first, and then Tomar kick it out to you, and then Sylvia out to you. So I have nothing to disclose.
I have no conflicts to disclose.
I have nothing to disclose as well.
All right. So as we said, you all are going to lead the way. I'm excited to learn. So I am ready when you all are.
Excellent. Thank you so much. So as you mentioned in the introduction, I do direct the Health Law Clinic. We're a medical legal partnership between Pitt Law and UPMC Children's Hospital of Pittsburgh. And, the work of a medical legal partnership, which involves placing legal counsel at the site of a medical care visit, is really rooted in this understanding that law is a social determinant of health, right? So when you're going to get your medical care, we're dealing with, your acute needs, but there are also other social needs that bear on a broader definition of health, on a fuller definition of health that includes well-being. And so when we're thinking about making people healthy from the standpoint of well-being, we've got to address those social determinants of health. And when you think about what those social determinants are, they're the conditions and the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And so when you're reflecting on what are those things that affect how I live, learn, play, worship, age, right? Those are where I live. Those are where I get educated. Those are where I go grocery shopping. What do I have access to? What are my resources? What are my social networks? And then if you think one step further, well, what determines where I get to live and where I get to shop and where I get to go to school? Law plays a very big role in all of those circumstances of living. So we can think about law as being at the root of social determinants of health, but we can also think about law, and here I mean law as the product of legal institutions such as the courts and legislative processes, as something that dictates the access to social determinants of health, and that law in and of itself is a social determinant of health. Among the social determinants of health, and I guess the reason why I got into thinking about race as a social determinant of health is because when I'm teaching in the context of my medical legal partnership clinic, sometimes I'm teaching law students in addition to nursing students, or students from School of Public Health, or students from School of Medicine. And so I'm trying to convey to the students that race is not just that it's not a biological construct, right? That race is a social construct. It's a social determinant of health. It's something that we created. And so sometimes I'm teaching and I'm comparing and contrasting the medical profession with the legal profession. And I saw an opportunity to look at the origins of race from both a medical and legal perspective, right? So we can think about how race was socially constructed through legal institutions, but we can also think about how race has been constructed through our medical institution. And so in my teaching, I focus on how race acts as a social determinant of health. I try very hard to convey that racial identity is what carries with it a series of circumstances that affect a broad range of health risks and quality of life outcomes, right? So it's not that there is a biological condition that is leading to these health risks, but really it's the social circumstances of being identified with a racial marker that impacts your health risk and impacts your quality of life outcomes. And when we look back at the legal history of racial subjugation in this country, we can see that that is really the genesis of a lot of the disparate health outcomes that we now see on the basis of race. When we review this history, we can say that constructs of racial identity date back to about the mid-1400s. We know from other scholars in history that racial categories and distinctions were created as a justification for slavery, for human exploitation, for other activity intended to secure economic and political gain. In what would become the United States, as early as 1640, we see law being used to institutionalize race as a social caste, right? We're creating this group, this lower social hierarchy on the basis of race. And this can be seen in the example of a gentleman who is known to us as John Punch. He was an indentured servant in the Virginia colony who fled his term of service with two co-conspirators who were also indentured servants. And we know this from the meticulous record of the Grand Court of Virginia, which you can go online and see for yourself, right? So this court was established long before the Revolutionary War, and in their record, they've documented that Mr. Punch was of African descent and that his co-conspirators were a Dutchman and a Scotsman. When the three men were apprehended, they were all punished with 30 stripes or 30 lashes, right? So we understand that they were whipped as part of this punishment. However, the Dutchman and the Scotsman were each sentenced to an additional 4 years of servitude. Mr. Punch, and they recognized by reason of his race, was sentenced to serve his master or his assigns for the time of his natural life here or elsewhere. And that's a direct quote, for his natural life here or elsewhere, right? So it was this idea of this permanence of punishment that was conveyed in the sentencing. And this disparate sentencing of John Punch is one of the first recorded examples of persons of African descent and those of European descent being treated differently under the law. So we can reflect on the effect of this unequal sentence for committing the same crime. The lesser consequence experienced by the European offenders, the retained opportunity to be free from bondage, suggests that their actions were somehow less transgressive simply because of their skin color. So we see the institutional power of the court to set and enforce penalties is now being used to propagate the construct of racial identity by obscuring whether its decision reflected either a man-made distinction or an inherent difference that the court was simply acknowledging, right? The power of the court obscures that. So now we have this reality of disparate sentencing, and we have a racial difference that now proves socially consequential, right? Because we've given people a reason to see themselves as intrinsically different from one another. And if you do that, if you condition someone's liberty on that difference, they will see themselves as being different, right? So we're creating a meaningful difference from a construct, from an idea. As U.S. history progresses, we see that despite the lofty language that's used in the Declaration of Independence in 1776, which we remember the part that says we hold these truths to be self-evident, that all men are created equal, that they are endowed by their creator with certain inalienable rights. The Declaration goes on to say, quote, that whenever any form of government becomes destructive of these ends, it is the right of the people to alter or abolish it and to institute new government. Now, if there was ever any question as to how that language was meant to be interpreted, we need only look to the U.S. Supreme Court's decision in Dred Scott v. Sanford, which is better known as the Dred Scott decision. This is 1857. Chief Justice Taney wrote that while the Declaration of Independence, quote, would seem to embrace the whole human family, it is too clear for dispute that the enslaved African race was not intended to be included, right? He goes on to write that the framers of the Declaration of Independence, quote, perfectly understood the meaning of the language they used and how it would be understood by others, and they knew that it would not be supposed to embrace, he uses a different word, I'm going to say Black Americans, okay? So this is how our country was founded, with documents that contain ideals that were not intended to include Americans of African descent. And Chief Justice Taney is writing this just 6 years before the Emancipation Proclamation of 1863. So we have to go back to the history. We have to go back to our American history. We have to go back to how the country was founded and how the courts were used to turn an idea about race into a social construct that we now understand has biologic consequences. But this is a social construct that was created through the institution of our legal courts.
Yes, so that was a great synopsis of how race became a social construct at the very beginnings of the history of the United States of America. It is always intriguing to me because when people ask me who's one of my favorite presidents of the United States, and you'll know where I'm going with this, one of my favorite presidents was Abraham Lincoln, because to my understanding, he freed the slaves, correct? But we have to understand the definition of freedom for some may not be the definition for freedom for others. And within this social construct, for which Tomar spoke about, race ended up playing a role in what we understood to be freedom, but what wasn't really freedom in 1863. And so at the time, blacks at baseline after slavery, the Emancipation Proclamation came into being. And in our history books, it says that African Americans were free. But because of the previous social construct that was built, they were at a disadvantage once they were allowed to have this quote unquote freedom when it came to rights, property, life, and liberty. What does that mean? How do I explain that? What do you mean by that, Dr. Owusu, that these slaves were not free? Well, they were freed from their slave owners, in which they had support economically, in which they had support through housing, in which they may have even had support through health. Not that that was the best construct for them. But once they were freed, they were then deemed criminals. Okay? So then the social construct for them, freedom became linked with criminalization, specifically for the African American population. And so, in essence, as freed African American men who were seen as criminals, they were put back to work. But they were put back to work with little benefit and on plantations with worse conditions than they had as slaves. In any way do I, there are philosophies out there to say that African Americans were better off being slaves. In no way do I justify that line of thinking, or am I encouraging that line of thinking. What I want to tack on to what my colleague has said is that this is a continuation of the social construct of anti-Black racism early on in our history, and that even in a point in time where we thought that African Americans were freed from slavery, in some ways they were made slaves once again, but under a different legality. And so they were no longer considered a property asset. And so their lives, their health, their well-being was no longer of anyone's concern but their own. And they were left without resources. Comparatively, with Caucasian populations, they were able to build up their assets, their property and wealth, and provide education to their families. And as you can see as we paint this picture, that leaves the African American community in a social construct where they're left behind, where they're not actually given the same rights to life, to liberty, to property, and to well-being.
Yeah, Sylvia, you're absolutely right. I was quoting Chief Justice Taney in the Dred Scott decision. That decision was ultimately reversed in part by the citizenship clause of the 14th Amendment in 1866, 3 years after the Emancipation Proclamation, right? So you'll remember that the 14th Amendment says that no state shall deny to any person within its jurisdiction the equal protection of laws. So again, the irony that Sylvia is pointing out here doesn't just sort of end with the institutions that put slaves now into sharecropping situation, though they be free men in name, right? We now have this equal protection language in the 14th Amendment, only to be followed by the Supreme Court's decision in Plessy versus Ferguson in 1896, which held that segregation does not violate the Equal Protection Clause of the 14th Amendment, right? So essentially, segregation is not unlawful discrimination. So now we're seeing more of this pattern of doublespeak, where we're saying one thing in name, but the lived experience of Black Americans is something quite different.
So let's go back. So we talk about the Declaration of Independence, and we talk about the phrase or the clause where all men are created equal. But we see here in 1896 with Jim Crow laws and the idea of segregation, or the implementation of segregation, that all men were not thought to be equal. It was quoted within the Jim Crow laws that the Jim Crow laws and the laws of segregation reflected customs and traditions of the United States at that time, meaning that segregation was considered to be okay. It preserved public peace and good order. Now we come back to the criminalization of the African American community, in particular African American males. And as we move forward through history, it will make more sense of kind of where we're going and talking about the social constructs of and social determinants of health and how race takes effect of that. So preserve public peace and good order. So the thought process was that a majority of these African American males who were sharecroppers, who were considered criminals, that we had to keep the peace and the order. And in order to keep the peace and the order, we had to be separate but equal. So this also continued to support the social ostracism of blacks, as they were early seen as criminals, or criminalization was noted early in our history. And this extended to many institutions. So not just sharecropping, but this extended to institutions such as education. This extended to institutions such as health institutions, where we talk about hospitals, and we'll get more into that. So speaking of education in particular, we go from 1896 all the way through the early 1900s, and now we're in the 1950s, where we're talking about Brown versus education. And we noted that there's social ostracism in institutions, including and probably especially schools. Now, in this case, separate but equal was struck down in Brown versus Board of Education, in which we argued that African Americans should be able to go to school with Caucasian Americans and other Americans. They should be able to be given that opportunity, that right, that liberty to get the same education. But interestingly enough, in an insidious way, even though that separate but equal was quote unquote struck down in Brown versus Board of Education, 5 states over that period of time passed over 50 new Jim Crow laws after 1954. So continuing the subjugation and the social ostracism of African Americans. And private white-only schools begin to pop up, dubbed segregation academies. It's predominantly within the South. Many of them were Christian, and that was after 1954 as well.
Can I ask a question? And Tomar, you may be the best person to answer this, or Sylvia, you may know this too, I don't know. If I'm reading the rule right, from 1896, the Supreme Court ruled, preserve public peace and good order. Does that imply the racist idea that black people are criminals in the law? Am I reading that right?
I think it implies that there was a social hierarchy, that there was financial and political capital to maintain, right? So when we're talking about institutionalizing race, we're institutionalizing a social hierarchy that is essentially a white supremacist social hierarchy, right? When you actually read the text of Plessy versus Ferguson, Mr. Plessy was a biracial gentleman, right? And the reason why this was set up as a test case, right? So they wanted to challenge the laws that were segregating, these post-Reconstruction laws that were segregating Black people and white people, because the idea is that if we take Black people out of the economic mainstream, we can maintain this idea that we're talking about a racially inferior group, right? So we need these, what they called the badges and incidents of slavery. We need these things that continue to mark this group as other. So we need segregation to mark them as other, so that there is a group that can continue to maintain political and social power. So it's not about, I agree that Black men have been unfairly criminalized. I feel that it is true that our Black boys have been unfairly criminalized. But I think when we're talking about the institution of segregation, it was an intentional way of maintaining a social and a political power structure to continue to preserve a system of racial hierarchy where Black people were at the bottom and white people were at the top.
Thank you.
Even after Brown versus the Board of Education declared separate but equal policies unconstitutional, it took decades and several years for school districts and hospitals across America to fully desegregate, and for more subtle forms of institutional segregation through policies like restrictive covenants and redlining to be surfaced and challenged.
Tomar, I'm not familiar with restrictive covenants.
Restrictive covenants refers to language in property documents like a mortgage or a deed to a piece of property that restricts who that property or that title could be conveyed to. So a restrictive covenant, an example of a restrictive covenant would be language that says, you know, you can purchase this property from me as long as you agree to never sell it to an African-American person or to a person of particular ethnicity. So these were informal things that were done to perpetuate segregation, to perpetuate otherness, to perpetuate racial hierarchy.
Exactly. So, as Tamar alluded to, it's taken a while to, and in some ways it hasn't fully gone away, some of the social constructs or some of the adverse effects of segregation. Continuing on in the 50s, there was a Southern Manifesto in which Congress members, 101 out of 121 Congress members from the South signed, and basically pledging to maintain Jim Crow laws by all means possible. So even though at the higher level of courts, a lot of these ideas or the idea of segregation was struck down, in reality, it was still happening in certain areas of the country, very much happening. Then we come to the late 1950s and 1960s, where, you know, many of us know of the civil rights movement, Martin Luther King Jr., Rosa Parks, Jesse Jackson, the list goes on and on. There are numerous folks that I'm not naming. Here we point out that there were predominantly peaceful protests, almost similar to after the murder of George Floyd in May of 2020, where a lot of these protests started out peacefully and occasionally broke out in riots, but the focus would be on the riots. And so those few who caused disruption ended up being the focus from a political standpoint to continue to, as Tomar has nicely explained, deem the African American race as the lesser race, and to allot the riots to the fact that the protests were for civil rights. And so if we allow for the African American community to protest, it might erupt in violence. We don't want violence. We want a peaceful and calm community. We want peaceful and calm communities. And Nixon and many other politicians took this opportunity to set in place what was called law and order. Again, part of it goes with the criminalization aspect of the African American community. But again, part of it has to do with the idea of the lesser race, the perpetuation of the African community being part of a lesser race, a less worthy race, a more potentially violent race. Again, some alluding to this being a biological issue, but as we have illustrated from the beginning, this is not a biological standpoint from which racism stems. It is a social construct that has been created through multiple systems within our country.
That is eerily similar to what's happening now in terms of the protests, the occasional riots, the government response, the law and order pitch specifically. That's remarkable.
Yeah.
Go ahead, Tomar. Sorry.
We're playing from history's playbook, right? We're seeing these things brought out over and over again, right? When you're dealing with a racial construct, when you're dealing with an idea, there are many opportunities to continue to try to reinforce the contours of that idea. And that is why it's so important for students entering the professions and for people who are currently in the professions, right? Both law students, medical students, lawyers, and medical professionals to really understand the history so that you can see for yourself that these are recycled ideas, right? Like we're trying to continue to spread the same lies, and they have consequences, right? The social becomes biologic. And there's institutional transfer from the way that the courts have been sort of used to entrench false ideas of racial inferiority and racial superiority. We can see that in the evolution of the medical profession as well. And I really appreciate that Sylvia focused on the civil rights era, because even during that time, there's a silence from the American Medical Association and the medical establishment in the face of civil rights and justice. We see that the medical establishment during that time was still supporting the maintenance of segregated hospitals, and that they resisted integration even after the passage of the Civil Rights Act in 1964. So there's this dovetail of the two institutions being used to reinforce and to attempt to maintain this social hierarchy.
I will tell you, from my perspective, as someone who's really learning about this in a much more aggressive way than ever, it struck me that I never thought about the history of race. The idea that it just is a social construct that white people invented at the time of the Atlantic slave trade to justify the slave trade. I just never, it had never crossed my mind as to the history of it, and it's remarkable. And you bring it out so very, very well. That's amazing.
So I would say, Tony, off of that, I had a discussion with Tomar earlier about my own brief experience, and we'll delve more into the history of this as well. I'm a child of two West African immigrants, and West Africans see themselves differently as African Americans. And so growing up, I saw myself differently as an African American child growing up, and I never understood where the frustration came from. I never understood why certain of my classmates lived in neighborhoods that I didn't live in. Why didn't they live in the same neighborhoods as I did? Why weren't things more integrated? Why was it that so-and-so's brother was, imprisoned for an X thing, and why weren't we all going to medical school together or becoming engineers or business folks? And I also acknowledge my own ignorance and prejudice in the sense that, I've always been taught that, if you work hard, it pays off. That mantra. Most of us, probably all of us here, live by that mantra, right? And grew up with that mantra. But in the back of my mind, my thought was the African American community just not working hard enough? But we see here that it is not about the effort. It's about the broken system. And that's what we all need to understand. And me, as an African American female, will openly say how ignorant I have been up until recently, delving into my own history as an African American female, that it is a systemic, it's almost like, as a physician, it's a systemic disease. I mean, you're talking about Kendi's book. He described racism as a cancer, right? As a metastatic cancer. And so I just think it's interesting, that I feel like all of us can learn from this. There's not one particular demographic that can pull from this. All of us can learn from this and move forward. And in continuation with that history and learning more and talking about my friend who lived in one neighborhood while I lived in the other, household wealth also has also systemically based off of segregation and racial constructs as well, unfortunately. And so as of now, unfortunately, the average Black household has 1/10 the wealth of the average white household in 2020. And this is definitely not by choice. And this is definitely not by lack of effort. This has to do with the social constructs, the racial social constructs that we have discussed. I'll start with the number one source of intergenerational wealth in America is home ownership. And so knowing that says a lot. So if we go back to history in the 1930s and 60s, again, we look at the legality of this. We look at the politics of this. The federal government actively encouraged white households to buy up homes and at the same time discouraging Black households. Federal Housing Administration deemed which neighborhoods were considered safe. And for simplicity's sake, neighborhoods that housed African American families or Black families were not deemed as safe as neighborhoods that housed white or Caucasian families. So the Federal Housing Administration were less likely to federally back mortgages in unsafe neighborhoods, which were predominantly housed by African Americans. simply put, the African American or black neighborhoods were just deemed too risky to support for mortgages. At the same time, post World War I, post World War II, veterans came back, otherwise known as the baby boomers, built up their families, and now there was a new community in which they could live known as suburbia, the new suburbia. So these were areas outside of the city that had larger homes, larger pieces of land, property areas, and those deeds were restricted to whites only, which Tomar alluded to earlier in the talk. So this is predominantly after World War II. So deeds for these homes were predominantly for white families only. You could not help a black family move into the neighborhood. Again, they were not deemed to be as safe if you had African American families in those neighborhoods. The cities were constructed in a way to separate African American neighborhoods and white neighborhoods. And if you look at some of our major cities today, such as Atlanta, Chicago in particular, New York, highways were used to divide white neighborhoods from black neighborhoods, in addition to suburbia. So white families, in essence, after the war, they were able to buy a home. And when you're able to buy a home, you can build up home equity and thus build up wealth. When you're able to buy real estate and invest in more real estate, you're able to build up your wealth that way. In addition, again, we're talking about post-war America, right? The GI Bill was given by the government to veterans to help them reestablish themselves after the war in the way of wealth, in the way of education, in the way of buying a home. Only a small percentage of the GI Bill was allotted to African Americans who fought in the war. The majority of GI Bills were given to white families, or white veterans rather. And so factories also then decided to move out of the city into the suburbs, again, which is where predominantly white families lived, or white neighborhoods were located. And as you can imagine, from a transportation standpoint and an ease of work standpoint, white Americans were able to get to work in a more timely fashion and more easily. They also had built enough wealth. They could buy cars in addition to homes. Most of the African American families in the urban areas stayed predominantly in the urban areas that we now know as, in some areas, as inner city. So it was more difficult for them to transport themselves to suburbia to work. And so over time, there was a drop in access to transportation and access to work. And initially in the 1970s, 70% of African American males had good blue collar jobs. And by 1987, only 28% did. Also, at the time that the factories were moving into suburbia, only 28% of African American males had access to cars at the time. So you can imagine having to use public transportation to get out to suburbia, to get work, and then back home in time to your family to help assist taking care of them, took a toll. Then we come to the 1980s and 1990s, where we see an increase in the incarceration of African Americans, in particular African American males. Again, history is once again repeating itself. So the same amount of whites and blacks at this time were actually using drugs, what we know as street drugs in the way of cocaine, predominantly in the 80s, 90s, cocaine, heroin, drugs of that nature. So the proportions were about the same, but in came a new drug, relatively new drug, but cheap drug that could be made at home, known as crack. And African Americans were able to access that particular form of cocaine more so than the pure form, I guess you would say, would be cocaine. And from a legalization standpoint, the punishment for using crack was more than for using cocaine. So even though there was a similar amount of Caucasians or whites and black African found to be using crack, more likely to be punished and for a significant duration of time, longer. And Tomar maybe could speak more details of that from a legal standpoint. You can kind of see where we're going with this. Now we're in the 1980s, 90s. There's not a lot of wealth. When there's not a lot of wealth, that leads to crime, that leads to increased drug use. And we're seeing that, interestingly enough, in rural white America right now, where a lot of rural America, there are not a lot of jobs. There's increased drug use, which now we're calling the opioid epidemic. which in the early 1980s and 90s, we were not calling this an epidemic per se. And it's just the natural inclination or the downward spiral of what happens when there's not enough employment to go around for everyone.
I gotta say, the first person to bring this up to that I noticed this, what you're talking about, was Dave Chappelle. He had a really nice, I forgot the special he had, but he went into this in detail. And honestly, he was the first one to make me think. I had never thought of it that way, that the opioid epidemic is similar to the crack cocaine and cocaine epidemic in the 80s and 90s. It's just now it's happening in a different demographic, and we care more as a society, which I think he meant for that to be how he told the joke, and that's exactly the effect it had. Was it brought out the racism in it, but that's remarkable. So I'm sorry to interrupt.
No, and that's fine. And the other point I want to make that was striking to me is that this crossed all political party lines. This was not a battle of the Republicans versus the Democrats or Democrats versus the Republicans. Anyone in power, from when we talked about the very beginnings of the start of the United States of America up until this time period that I'm discussing, had a hand and a role to play in mass incarceration and the criminalization of African American males, stereotyped as vicious criminals. Some people remember Dukakis running for president, the Democrat running for president, and one of the African American males that he freed was deemed criminalized by his opponent on national TV. And even though Dukakis was ahead in the polls, ended up losing that presidential race. And the thought was, part of it had to do with the society being told that, hey, this particular presidential candidate let out an animal or a monster or beast or a criminal. And so that kind of continued throughout. Even with the next Democratic administration, the Clinton administration, Clinton has since apologized for playing a role in mass incarceration. And so it basically doesn't matter what political views you have or what political party you support, the social construct still remains.
Yeah, I agree with you 100%. And as I've said earlier, the social has biologic consequences. The economic and environmental differentiations that divide along racial lines have consequences. And this is really essentially what I am trying to convey when I'm talking about race as a social determinant of health. All of these consequences that Sylvia has laid out through history, from the civil rights movement through mass incarceration to the circumstances that we're seeing today, fall differently along racial lines. And those that in turn underlie the health disparities that we're able to observe in our patient populations, either the patients that we're serving through direct medical care or the patient families that we're serving through the legal services that we provide to patient families. The ways that Black Americans have been treated across history to the present is exactly the reason why race is a social determinant of health.
That is true. It affects our patients as well as our workforce. So the physician workforce is currently less than 5% of all active physicians in the United States of America are of African American descent. Less than 5%. And again, it stems from a broken system. Currently, across our diaspora, UPMC GME, the percentage of Latinx and African Americans is 8%. So what do I mean by GME? Sorry, graduate medical education. So education after undergraduate, only 8% compared to the national average. So for the same population, only medical school applicants and matriculants are 13.3% for African Americans and 14.6% respectively. So one may argue that there's a long way that we ourselves need to go here in Pittsburgh. Currently, I can speak from experience at UPMC Children's Hospital of Pittsburgh, less than 1% of our faculty is African American. So as Tomar discusses social determinants of health and health disparities, we know that underrepresented minority, particularly African-American populations and Latinx populations, are more likely when they complete medical school and residency, go back to those underserved neighborhoods and serve their community. And so to have this significant deficit is detrimental to our own population, in which Pittsburgh African-American community population is children desperately need to see medical providers that look like them for numerous reasons. The Association of American Medical Colleges has kept up with this data over many years. And the latest data, I have the 2018 to 2019 data. African American students, go back to talking about household wealth again, and wealth in African American communities versus white communities. African American medical students have the highest amount of pre-medical debt of all U.S. medical school matriculants of any race or ethnic group. That is even including the Native Americans. So more than 25,000 for 40.5% of African Americans, compared to 13% for white counterparts. So that is significant. The percentage of applicants to U.S. medical schools by race and ethnicity, it's African American is 8.4% compared to Caucasian or white, which is 46.8%. And so this is where the idea of pipeline programs, holistic, sustainable pipeline programs, are very important to consider, in which we reach out into our communities and to our youngest folks to let them know that they can be doctors, lawyers, and engineers too, and to see more people that look like them. Continuing on with the data for medical graduates. So percentage of medical school graduates in the United States, Blacks are 6.2% compared to whites, 54.6%. So that's a significant difference there. And the also troubling statistic when it comes to medical school in general is that there's a significant decline in African American males who are applying to medical school. So since 1986, there's been a 39% decline in African American male applicants to medical school. So patient population, Tomar kind of touched on this with health disparities, but we also need to remember, in dealing particularly with the African American community, that there's a long-standing mistrust with the medical community. And that's another thing that we need to address from a systemic standpoint, and that we need to be very aware of when we take care of our patients. This is a quote from an article in the New England Journal of Medicine. Slaves provided economic security for physicians and clinical material that permitted the expansion of medical research, improvement of medical care, and enhancement of medical training. So many of us have heard of the Tuskegee experiments, more recently HeLa cells. Not that it happened more recently, but we're more aware of the misuse and the mistrust of African American communities when it comes to advancing medicine and science. And so that is another part of the social construct that needs to be addressed on a continuum and not forgotten about when we take care of our patients in the African American community.
Yeah, absolutely. The social construct of race has shaped the experience of medical care. And here again, when we look at the history, right, the history of medicine in this country demonstrates, as Sylvia has shared, not only did physicians use science to provide justification for the subjugation of Black people as a race, physicians used racism to their personal and professional advantage. So, for example, enslaved persons and other disenfranchised Black Americans were intentionally exploited as material for developing treatments, for exposition for different surgical procedures. Sylvia mentioned the Tuskegee experiments, which are very well known. There's a really great text by an author named Harriet Washington. She's a historian. Her book is called Medical Apartheid. In her text, she chronicles how physicians like J. Marion Sims, who in the mid-1800s gained profit and prestige within the medical profession for his surgical technique to repair vesical vaginal fistula, which is a complication of childbirth. He developed this technique through the forced genital mutilation of an untold number of enslaved Black women. right? So Black bodies have a history of being used unethically for medical study, and the physicians who engage in these unethical and immoral, quite frankly, practices have gone on to accolades and to benefit and social status. We can even think about the eugenics movement in the United States as an example of this, right? So this is a movement that's advancing the idea that human progress depends upon promoting reproduction among those deemed socially superior, right? Which is code for members of what is being called now the white race, right? So people of European descent. Oliver Wendell Holmes Sr., who was a previous dean of Harvard Medical School, was one of the first American intellectuals to espouse eugenic beliefs, right? So we have physicians and we have the medical establishment in this country benefiting from and manipulating and propagating white supremacist ideas to their professional gain. All the while, they're reinforcing this idea that race is somehow real. They're taking this social construct and they're wielding it in such a way that now we're seeing real biological consequences in our bodies, in our experience of medical care, and in the social mistrust, as Sylvia puts it, of the medical establishment.
And to add on to what Tomar has so nicely illustrated, in continuation with the article that I quoted from earlier in the New England Journal of Medicine, it specifically states, and I quote, "Discrimination and racism as social determinants of health act through biological transduction pathways to promote subclinical cerebrovascular disease, accelerate aging, and impede vascular and renal function, producing disproportionate burdens of disease on Black Americans and other minority populations."
That's saying racism itself is causing issues disproportionately with Black Americans and other minority populations, simply because of the social determinants, how it acts as a social determinant. Am I reading that right?
Yes.
So if I can ask, there's a movement, and the last podcast episode we did on racism in medicine, I talked with Edwin Lindo on this, and there's a movement to almost remove race as one of the factors to look at for things like chronic kidney disease, asthma, UTI, because the studies that have shown Black people or African American people are disproportionately affected, there's been no studies to talk about the systemic racism that has potentially led to a higher proportion of difficult to treat asthma, let's say, in the African American population because of kind of the topics you brought up. There was systemic racism on putting all people in one specific location, and more factories come up and air pollution comes up in the poor areas, and that can lead to it. So do you fall on a specific area on that, on a specific side on that movement in terms of removing it as a factor and more looking at the systemic racism itself?
So, I'm not a medical professional, but my sincere feeling is that we have created now a social double-edged sword. And what I mean by that is we are now entering into the mainstream of conversation, this idea that race is a social construct, right? So there's not a biological reality of race. I think I had the opportunity to listen to that podcast you mentioned, Tony. And so they were talking about, look, there's no gene for race, right? It's not a genetic reality. But just because it's not a genetic reality doesn't mean that race does not have biological consequences. And I think that that's what the quotes that Sylvia pointed out, that's why they're so meaningful. And we really need to meditate on this language, right? Because now we're in a situation where if we were to stop collecting public health data, say, and dividing it out by race, we miss a critical piece of the puzzle of how disease is spread, what is the breadth of social disparity, and what is the breadth of the disproportionality, so that we know that we have an institutional failing such that we need to allocate resources to address the health of people by racial demographic groups in a different way. So for example, everything that's going on with COVID-19, there are states who are counting their cases of positive COVID tests by race, and there are states who are not. So we don't know how the disease is affecting people based on demographics. But where we do have race data, we see a disproportionate effect on Black communities. So what does that say? It's not, I think it would be, and I'm not a doctor, but I think it would be a misread to say, oh, well, there's something about the biology of Black people that somehow makes them susceptible to the disease. And I think that what needs to be more so highlighted, what I think is more accurate read of this information, is to say, what are our social systems and processes? What are the institutions that are set up around Black Americans and access to health that is resulting in their disproportionate bearing of the load of disease? So then we've got to come back and look at the legal history and say, well, why is it that Blacks live in these regions? Oh, because we made it legal to discriminate and decide how people are going to live. We made it legal to discriminate and decide how people are going to have access to economics. We made it legal to decide how to discriminate and limit access to education and resources. So now we then see a social consequence evidenced in medical burden, who's carrying the load of prevalence of disease in an area. So the counting by race is important because we're never going to be able to surface the social and systemic consequences of categorizing people by race if we don't count certain medical outcomes by race. But that should not be confused with there being some sort of real biological existence of racial differences.
So again, I think Tomar put it eloquently that I think we need to address that there is systemic racism. I think we need to address that there are racial social constructs in which, once we are aware of those things, we can help to address those issues and come to a solution. And as far as more of the granular data and looking to different racial and ethnic groups, we need to know what race in which we're talking about within a certain disease process, I think, to address those issues as well. For instance, asthma, diabetes, cardiovascular disease. It's similar, but very different. For example, the rates of, asthma in African Americans versus Native Americans. And so we'd like to group them all as the underrepresented minority group. But when you're going to tribal health versus an underserved African American community, your focuses are going to be very different. And you wouldn't know that if you had not delineated your data by race. So, and I think we could potentially get in trouble in kind of collectively seeing underrepresented minorities as just one group if we get rid of race and we don't address the particular issues for each community in which to make them healthier and stronger. So I think you need an understanding of both. I think for so long, we have focused on the race categories and kind of dismissed how did we get here, which is basically what we're talking about today. And so I think we need to catch up on the how did we get here. So I agree that we need to understand the roots of this, of the racial social construct, and figure out a better way to address it, along with the data that we currently have and continue to collect on different races and ethnic groups per certain pathologies, per certain medical issues, if you would say. So I think we need both. We need to address both. I think one cannot work without the other to really understand the problem and to find a solution to the problem.
Tamar, can I ask you, with everything you all have very eloquently put together in terms of walking us through the history of this, to me, it stands out that there's going to have to be multifaceted ways to get out of this and to solve the problem. But what strikes me, and I've read some from Ibram Kendi and other articles, and then Robin DiAngelo, that policy, U.S. legislative policy, which I'm not experienced in at all, is going to have to be kind of the main driver of systemic change. Would you agree with that?
I agree that policy is a key driver of systemic change. And some of my scholarship focuses on systems thinking as a way of sort of understanding the nature of change, right? And so from a systems thinking perspective, we see, events and patterns of events, we see systems, and we can write policy that targets those systems that are then producing the patterns and the problematic events that we see, right? So there's this approach that says, well, the system is broken, but we can also turn that on its head and say, well, the system is actually producing the results that it was designed to create, right? Like, so we used policy to create a social hierarchy, and we in fact have a social hierarchy, right? So policy can play a role. We can pass a law that says everybody's equal. We can pass a law that says discrimination is legal. From a systems thinking perspective, I would add one more layer to that and say that we also need to think about the values that undergird those systems. What are the beliefs and the mindsets? What are the values? What are the identities that we hold on to that allow the system to continue to go for the way that it has, right? Sylvia and I started back, at the beginning of this podcast with 1,400, and here we are today in 2020 talking about the same thing. So we really need to ask ourselves, what are the values that we're holding on to? What has endured and become so important to us that we have allowed the system to continue on in this racially discriminatory, inhumane way for so long? And that's what's really going to turn the needle on policy, because we can pass a law tomorrow that said any number of things, but if our values haven't changed, we're going to see that pattern of placing a law that's designed to produce outcome X, but still getting outcome Y, and then we'll have confusion. So we need to be really clear that there's a relationship between all of these things. All of these things are tied together. And I firmly believe that we need to be reflective and surface what our underlying values are, so that as we write policy and really writing policy in such a way that we're changing the structure of our current systems to then produce new outcomes, we will have sustainable results. That is what will make policy an effective tool for change in the long run.
That was great. So what can we do, those of us who are in medicine, to even the playing field? What can we do?
So there are several things that we can do. So in addition, or to support what Tomar has said, I think it's really key in medicine, as well as in the community, as well as in legal constructs and political constructs, to change the mindset, right? That policy is not enough. We need to think of this as a new order, a new way of being, that we are truly created equal, and that we should see each other as human beings. And that when we put policies into place, we should think about sustainability. That it's easy to get caught up in this momentum, particularly now after the murder of George Floyd, of anti-Black racism, Black Lives Matter. These are great agendas. These are great purposes. These are great movements. Don't get me wrong. My concern is in 2040, will we still be talking about this? Will this still be on our top 10 priority list? And so I think when you are putting together policies or programs, you have to keep that sustainability in mind. So certain things that we can do in medicine that have been fairly popular over the years. The question is, what have the outcomes been? Are medical, what we call pipeline programs. Pipeline programs is when we go to the community, when we don't wait for the community to come to us. We don't wait for the African American medical school applicant or a University of Pittsburgh applicant to come to Children's and say, I want to be a doctor. We go out in the community to the Pittsburgh public schools and say, you can be a doctor. And these are ways that you can. And look, there's somebody that looks like you that got there. Let me help you to get there. And also understanding and asking the community what they want from us, how they want us to help them, and not putting our potential biases or prejudices or inclinations to help on the community, but asking the community, how could we best serve them? So in pipeline programs, we reach to our youngest in the community to begin to talk about science, to begin to talk about medicine, so that they could see that it's a possibility, that they can look to Lawrenceville and that multicolored building and say, I could work there one day, and that it's a true reality. But at the same time, that they're aware of the hardships and the obstacles it may take to get there. I was listening to a program the other day that was successful. It was a pipeline program in which they stated that the program was successful because they involved the parents. There are many pipeline programs in which we go into schools or community centers and we interact with the kids, and they go back home and they have to deal with their environment on a day-to-day basis, which may be grueling, and they may be overcoming obstacles that we're never aware of. And a lot of times when this happens, a lot of these kids do not succeed in these programs just because there's just a certain pool at home or even within the community. But when you involve the entire community or the families or the parents, children seem to go a little bit further. So currently, UPMC Children's Hospital of Pittsburgh is putting together a pipeline program with Arsenal Middle School, which is the middle school within our community, which is a walking distance in Lawrenceville, where we're asking the principal, what can we do for you so we can get more kids at UPMC Children's Hospital of Pittsburgh working there in many facets, not even just in medicine in particular, but research. It may start off with talking about medicine and science, but it may be research and maybe other aspects, child life, that the Children's Hospital, they can be a part of, and that can enrich their lives. So I think medical pipeline programs are necessary, but I think we have to be careful. We have to involve the community and do a needs assessment and find out what the African American community needs within those programs for them to succeed. And when I say involve the community, I say involve everyone, not just the children, the parents, the grandparents, the caregivers, the community advisors, the community organizers, to make it sustainable and lasting. Also have to have an intentional commitment. Not this to be hearsay, not this to be lip service, to say that, yeah, we're doing this in the midst of the current momentum of anti-Black racism, but this is something we want to be sustainable. We have to commit to sustainability. So we have to be patient, knowing that it may take a long time to develop and to have fruition of these programs, but staying in for the long haul. The other aspect to this that's really struck out to me is specifically physicians, African-American physicians in the medical workforce and the lack thereof, is the financial aspect of things. Again, we have established today that this has been a social construct. This has not been by choice. This has been a systemic issue. And how does one think about becoming a doctor how do they get to school? How do they think about incurring debt and paying that off as a physician? And so what I'm getting at is that we need to begin to think of a holistic approach to address this. We know that, providers who have some sustainable wealth, who have some savings, who have minimal debt incurred, are able to invest back in their community. They don't have this financial burden. And so thinking about, underrepresented minority faculty or trainees in ways to help pay off school loans, and not just in the way of loan repayment program, but in the African American community, on one side, there are not very many of us who are in the financial realm, right? Who are mortgage advisors or hedge fund advisors or out on Wall Street. The other side of that is there are many of us who don't know how to build our financial wealth, even if we had it. We're not aware of stocks and bonds and investments and Wall Street in general. And so what I would encourage programs to do is not only help to pay off the debt, medical programs, I'm talking about medical institutions, but find a way that once that debt is paid off, to use that growing savings and wealth to have the resources to financial advice, and intentional financial and directed financial advice to continue to build wealth. Third part that we talked about was real estate. So let's say if you have a new African-American African-American physician, either female or male, coming to your institution, having resources beyond pamphlets on real estate, on how to buy a house, what types of mortgages are there out there, addressing the financial aspects of being an African American from all sides, and addressing most of the things that we're talking about from more than one particular aspect. So then you have the total well-being of an individual who comes and then can focus on taking care of the population, which then transcends that you can invest more in the community, you can invest more in taking care of those of our community with health disparities, and there's more to go around because there's less burden. So those are some of the recommendations that I personally would recommend, and I've personally been pushing for at my institution.
Tomar, I'm going to begin to wrap up unless you have anything you wanted to add.
No, I thought this was great. Thank you for the questions that you asked. I learned so much from Sylvia's presentation, and I really appreciated getting the chance to be a part of this.
Well, I have to tell you, I've learned a ton. I sincerely appreciate both of you being on, Sylvia and you, Tamar. It was it's very educational, and I really enjoyed it. So thank you both for your time. Thank you both for your expertise.
Yes, and thank you both. I've been extremely enlightened by, well, one, I want to thank Tony for the opportunity to be able to talk about this particular aspect of systemic racism and racial social constructs. And I don't think we hear about a lot. We hear a lot about health disparities and to some degree social determinants of health, but we don't really hear about how we got here. So thank you for that opportunity. And within that, thank you, Tomar, for enlightening us even further from a legal standpoint, because I can speak for myself as a physician when it comes to legality issues, especially when it comes to our African American community. I am very deficient in that. And so I have learned an immense amount, even for myself, like I say, as an African American female, a wealth of knowledge that now I can be able to impart with my colleagues, and I'm appreciative for that.
Thank you. Thank you. I feel likewise about the information that you shared. It was really helpful to get those statistics, and it was making me think I've got to get those same stats for Black law students, because I know that our numbers are just as dismal. So yeah, I feel like I gained more than I probably contributed. So thank you all so much.
Now, for those of you listening at home, what we normally do here is I have an exit where I thank the University of Pittsburgh, which I will, for the free CME and the support, and UPMC Children's Hospital of Pittsburgh and my division, the Paul C. Gaffney Division of Pediatric Hospital Medicine, for the support. And I usually have music and my kids at the end saying thank you for listening. Today, we're going to do something a little differently. Dr. Sylvia Owusu-Onsah has written a very beautiful poem that I have heard, and she has been gracious enough to read it, and that is how we're going to exit this episode.
Thank you, Tony. I have been a pediatric emergency medicine physician for over a decade. I take care of any child that walks through our emergency department. I do my best to make the children feel as comfortable as possible, to make them smile, to make them laugh, to forget about their troubles by blowing bubbles and drinking Slurpees. I wipe your tears away, and your child as well. Before COVID, I would give high fives and hugs. It did not matter what age, race, creed, sexual, or gender orientation. All I want to do is make sure your children feel better. I have taken care of your children on the brink of death, as well as kissed the little boo-boos away. I have taken care of your children when their eyes were red and swollen, when they could not see or had trouble hearing, when their ears hurt, when their bones were broken, when they had trouble walking, when they had a cut or bruise on their body, when they choked, when their chest hurt, when they had fever, when their skin was itchy, when their body could not stop shaking, when they had an infection, when their blood cells overtook their body, when their immune system was low, when their stomach hurt, when they couldn't eat or keep anything down, when they needed surgery, when they had trouble growing, when they were anxious, when they were depressed, when they were yellow, when they were assaulted or shot down, when they fell, when they wanted to hurt themselves or someone else, when they could not stop bleeding, when they swallowed poison, when their heart stopped, and when they could not breathe. Your children have taught me that I am not perfect or a mini God in the field of medicine. They have taught me about love, patience, kindness, reconciliation, maturity, interpersonal skills, acceptance, humility, and bedside manner. They have made me a better doctor. As an African American female with biracial children considered Black in this country, I ask you this question. Will you take care of my children? Will you take care of my children when they walk into a store to buy something? Will you take care of my children when they are driving a car? Will you take care of my children when they decide to wear their hair natural and flaunt their West African heritage? Will you take care of my children if they get sick? Will you take care of my children when they get an education? Will you take care of my children when they decide to buy a house? Will you take care of my children when they walk into a neighborhood or school where they do not feel welcome? Will you take care of my children when they need a shoulder to lean on or someone to talk to? Will you take care of my children when they go for a walk? Will you take care of my children when they ask for help? Will you take care of my children when they are just plain tired? Will you take care of my children and help protect their future and their future offspring? Will you take care of my children when they get bullied? Will you take care of my children when they decide to wear hoodies? Will you take care of my children when they are hungry? And will you take care of my children when racism rears its ugly head at them? Just know I will always take care of yours.